Record.
Yeah. I mean, to that point, I had a client who, she has told me that she's seen with everything kind of over the span of like 70 different doctors, I think she had kept track of. And she's like, she said, like, I fired most of them because they just, weren't the right fit. And, I told her, I was like, well, I'm, so proud of you that you've been, kind of keeping up and not like advocating for yourself and recognizing, when, it's not working or maybe we need to add something back in. But, here's someone sitting here with a lot of the things that you were describing with like IBS and a possible endometriosis diagnosis, but it's never been confirmed. And a lot of times even the endo can be a cause of all of the bowel issues, that sort of thing too. So, I'm sitting there and I'm like, well, and I asked her, I was like, well, is that the endometriosis? Is that something that you've ever kind of explored or are even open to exploring? Because at this point, I don't know. She's seen 70 different doctors, and where is she on the path of what she wants to focus on now? And, fortunately, she said yes, and I did refer her to you. So hopefully you'll be seeing her soon. But to just sit there and 70 different doctors, I was just like, my goodness. And a lot of them she fired because she was like, they just were not listening to me and they were dismissive of what was going on. So even being able to, like, the language that we use with our clients is so important to not make them feel invalidated or sound condescending or like, oh, like this is, I know what this is, like I can fix this, because it's not quite that simple. And I think we've had people who have come in and seen a bunch of practitioners and are told like, oh, it's just this one thing, like I can fix that. And then they go for 10, 12, 15 sessions and they're still having the same pain. And then people think, what's wrong with me? So, just listening and validating and understanding that everyone is complex and unique and different. And it's probably not just one thing that's going on.
Yeah, it usually never is. And then the whole mental health component also feeds into it hugely. And so validating that in terms of the anxiety and depression that can go along with the chronic pain or the trauma, and I think having the sensitivity towards that and the understanding, and also understanding just how chronic pain really changes your nervous system is so important. And that giving that explanation to patients about why they're, it shouldn't necessarily be painful, they become painful, and the upregulation of the nervous system. So that is all stuff that I'm still continuing to learn and understand. Because again, that's actually, it's really more neurology, so to say. It's not your typical OBGYN, but it's so important to understanding pain and chronic pain. And as far as endometriosis goes, maybe reasons why people, you may resect their endometriosis or treat them, but they may not feel better. They still have the pain, and it may be any number of reasons, but part of it is sort of endometriosis related pain that may be from some of that central sensitization of the brain and the peripheral nervous system.
And we know too from research, and I can't remember if it was an animal study. I can't remember if it was an animal study or it was a human study, that we know that endometrial tissue can actually kind of embed and graft itself into nervous tissue.
Correct.
So, like, of course, and you can't go and excise that. Like, you can go and excise that, like maybe around the uterus or around ovaries or fallopian tubes or something like that. So it definitely, even if somebody is diagnosed laparoscopically and surgically with endometriosis, they still need that support potentially afterwards, depending on the severity of what they've been dealing with. And that's kind of the best part of working collaboratively with people, is that, like, if you're managing like the medical pain modulation of it, we can help teach them, like, well, this is how, if you're getting nervous and there's pain with intimacy, like, these are all the things that you can try before to help your nervous system to calm down and recognize that things are safe, and kind of help to rewire that brain body connection. So it's just so amazing. I think the more we learn about pelvic pain, the more we have to continue to say, nope, this is a community party. We are all coming together and working. So I was going to ask you, I think the painful period thing is something that we see a lot in our office as like a history for somebody, whether they've had a baby or not had a baby. What are some things that is kind of something that you like, little nuggets that you've really noticed that like people who have endometriosis, before you even maybe do a laparoscopy, are things that they could actually be monitoring on their own to help them kind of advocate for themselves more, whether they're going to the gynecologist, whatever, more than just like, oh, I have cramps and it's a painful period.
Right. So, I mean, as far as endometriosis goes, there's certain histories of what their periods are like. So a lot of women that I'll see, or when they were young girls, their periods have always been painful, and not painful where they have some cramping and can take Motrin, but painful to the point of missing school, missing work, debilitating cramps. And so that, and that has been normalized for people where they think, okay, my periods are supposed to be painful. I am just out for the count for a couple of days. That's not how it's supposed to be. And certainly some people, when they're younger, can have more painful periods. And then that can kind of resolve. But in terms of endometriosis related pain or symptoms, one of the primary symptoms would be this cyclic pain around the period that would eventually over time also become continuous. So it starts extending not just from the day before the period and during the period, but throughout the month, to the point where it kind of becomes all the time. Often people also with endometriosis, although the initial symptom is this dysmenorrhea or very, very painful periods, it's also that they may have painful bowel movements if there's involvement of endometriosis or inflammation near the bowel. It doesn't have to be on it, but near it. Or they may have urinary issues or pain with their period. Or if they're sexually active, they've always had painful sex. So those, they're sort of called the 3Ds, the medical words, dyspareunia, dyschezia, and dysmenorrhea. So that's painful sex, painful bowel movements, painful periods. So certainly, those sort of three things, if I'm talking to someone, are going to really alert me to the fact of endometriosis. But also, they may have been started on a birth control, and that's not a bad thing at all. That's the first thing you can do, is try to see if someone's pain can be monitored or made better with medication. But if it's not, then sorry, there's nothing really else I can do. That's really when you start to think even more so about endometriosis and the importance of treating it early rather than waiting and it wreaking more havoc in the pelvis with inflammation and pain and adhesions. And the diagnosis is with a laparoscopy. So we need to look inside. We need to remove what's there and give people a diagnosis. I had a patient recently who I was sure had endometriosis based on her symptoms, but also had very significant pelvic floor dysfunction. And she just needed an answer one way or another. She did not on laparoscopy have any evidence of endometriosis. So we're really gearing our treatment towards pelvic floor dysfunction. But I think, 70 to 80% of people that have chronic pelvic pain, women, it is endometriosis. Incredibly common reason to have pelvic pain. And even in the adolescent population, although the prevalence is not known, the ranges are 60 to 70%. So that, and as it relates to infertility as well, that may be another reason why it may come up, as there's association, 50% of those with infertility of endometriosis. So there are different things that cue you in, and that would cue me in to pursuing that with a patient as far as endometriosis goes. And it's just so much more common than a lot of practitioners think.
Agreed. And just from like a personal experience of having pelvic pain, you go to all the doctors and expect that they do ask these questions of, have you had pain with your bowel movement? Had you had pain with sex, or had you had bladder discomfort? And many a times that those questions are not asked at all. And if you have a goal of becoming pregnant or have had multiple miscarriages and no one has stopped and said, is there an endometriosis history? And it's like, oh, well, just do IVF. It's like, that might not be the key too, that you do have to address sometimes this underlying inflammation for women to have more successful pregnancies. But it's very interesting to see that, you know, a lot of like the reproductive endocrinologists, the fertility doctors are not always asking about your period history, even though like you're there to get pregnant. No one's asking you about like, what was that? So I think it's super important for people to understand, like, you know, even if the goal is to become pregnant or not to become pregnant, somebody should be asking all these historical questions. So
Absolutely.
yeah,
And unfortunately, the limitation can often be with time.
exactly.
That some of these questions, you know, there isn't time in your standard
Mhm.
15-minute appointment to get into
Mhm.
all of that, which is
Right.
part of why I really enjoy the fact that I can have a longer consultation and the
Yeah.
packets to really get this information,
Mhm.
because that is very important.
I agree.
What are some of the things that people might be saying that are cueing you more into like pelvic floor dysfunction, kind of being a little bit more of like the path that you want to explore before maybe doing like a laparoscopic surgery?
Yeah. So for the pelvic floor dysfunction, often they'll come in and it's not so much that they're having pain around their periods. That's not the primary symptom. They may be coming in because they have a heaviness that they feel in their pelvis. They feel like they have a bowling ball or something is falling out. They have painful sex, and that's sort of their primary thing is the painful sex, and that it's always been painful for them, or maybe it recently became painful. Let's see what else. Sort of this aching, sometimes throbbing pain. Often it's not constant. It could be more episodic, where it kind of comes and goes with the shooting pain that they'll have. So those are the things that typically will cue me in more towards the pelvic floor. Also, often bladder or bowel dysfunction. So maybe even if it's a history of constipation, so I know that there's sort of been strain on that pelvic floor, or bladder dysfunction, whether sort of incomplete emptying or frequency, waking up in the middle of the night a lot, or difficulty starting their stream, things like that, that may cue me into the pelvic floor. Or if they've had potentially a traumatic vaginal delivery, something where they've been pregnant and there's been some stress or strain on the pelvic floor, or an injury, even you know, a hernia, any kind of thing that could have affected the pelvic floor that's sort of causing that sort of type of pain. And the words that they use, and that heaviness, feeling like something is falling out, aching, you know, those are the adjectives that I tend to hear more, not so much. And sometimes burning, that will be a descriptor for sure. But it's not, you know, the related pain is usually not the primary thing that they're coming in with.
Yeah, and then in that case, that would be maybe more where you're using the treatments as far as like the Botox or trigger point injections, any like, you know, topical creams. I know with medication, like suppositories or that sort of thing, that people can use just locally, even to the tissue, to help kind of reduce any like muscle spasm or anything like that in the area that can be a driver of some of those things, where especially like, you know, people think like, oh, I feel like my vagina is falling out, or I have like a golf ball in my rectum or something. They're scared that they have a prolapse, and on exam they have no prolapse, but you're finding all of this like very tense, tight pelvic floor muscles that can mimic the same kind of symptoms. So
Exactly. And the thing that's so important will be during my exam, when I am assessing their pelvic floor, which is obviously not anywhere close to what you guys do, but at least for me to get, you know, to feel the pelvic floor and see, am I reproducing any of their symptoms or finding any of that pain that they have during sex, or that throbbing, aching pain. And that can really help the patients understand, because sometimes if you say this is more of a, you know, musculoskeletal, myofascial, and explain that, people might think that that's like not a big deal. But I said it's a huge cause of pain, and you know, I am pressing on these different muscles, and this is what's causing that. So it kind of helps with the light bulb going off for the patients. The treatment for pelvic floor dysfunction, obviously a lot of the meds are off label that we use, but can be very helpful. So, I mean, first and foremost is always physical therapy. It's always the thing that I'm going to refer patients to, and talk to them. People incorrectly think, oh, I need to do Kegels. And I'm saying, no. That's the reverse of what we need to have happen. We need to, be relaxing and retraining these muscles. Medications, we use off-label vaginal Valium to help with the pelvic floor dysfunction. They're muscle relaxants from Flexeril to baclofen to tizanidine that one of my mentors in fellowship actually said, listen, I have people place them vaginally. So I will have people do that vaginally if they can, just potentially for a more local and less systemic effect. There's also the tricyclic antidepressants. They can't, like your amitriptylines, they can have side effects. So I don't, those aren't my go-tos.
Right.
Certain SNRIs that can help with overall pain. But again, that's going to be more if I think there's been sort of a central sensitization type issue, not always for the pelvic floor.
Right.
And then trigger points, I will always offer them. Usually that can help kind of diagnose and be therapeutic as well, especially in the abdominal wall, can help tremendously. Botox, I reserve that for once treatment, more of the physical therapy and some medication that they've tried hasn't worked, or if they've already gone through that. But Botox is something that I will offer them to the pelvic floor. And then certainly there's frequently maybe a component of cognitive behavioral therapy or some sort of stress management, dietary changes, things like that. Bowel regimen if there's constipation related or diarrhea related issues. So kind of looking at that, all of that. And then, if it's much, much more severe, you're talking about maybe sacral neuromodulation with the hypogastric nerve block or a stimulator, but that is going to be way down the line of, and that's going to be something that I'm referring, or there's obviously a lot of other pain going on.
Right. And I think that's, a lot of clients I've had the good fortune to work with a lot of people who have endured chronic pelvic pain for 20, 30, 40 years. And, they'll say to me, oh, 20 years ago, and they're on like year 30 of pelvic pain, somebody told me to just do a stimulator. And it's like, but no one ever did like the pelvic floor, therapy or any of the medications, or just a good combination of all of those things. And they get the stimulator and they're so frustrated and they're so bummed and they just, so I think it takes someone who's, like we said, like going to step along those paths and see, okay, let's do increments at a time. It doesn't mean we have to jump to this, or it doesn't mean we can't jump to this, but it's something that you need to, as a team, work together to decide.
And there's no one size fits all. So it's so variable from patient to patient, what side effect they may tolerate, how they may respond.
Right.
So it's really a little bit of trial and error in the pelvic pain world, because for some things there's just not as much evidence or algorithms as to this is exactly how you treat this thing, like there is for hypertension or diabetes. There's really a much more regimented way, and pain is very subjective in a lot of ways in terms of how different people may experience it. So that's why it really is, each person is their own, really have to deal with them individually.
Definitely.
Yeah. And a lot of times people on that path of 10, 20, 30 years, they've tried each thing, but at separate times along that. Whereas sometimes it's like, okay, well, did you ever do, the medications with pelvic therapy, or the injections with pelvic therapy, or that with pelvic therapy and acupuncture, and seeing like behavioral medicine to help with, kind of all the psychosomatic kind of components of it as well too, where it's like you'll get people where they're like, I've tried everything, but they've tried everything at separate points, where maybe it's no, we need to get these 3 or 4 kind of modalities all working together at once, so that we can address the multi kind of factorial things that are contributing to, like you said, because chronic pelvic pain, there's so much of a nervous system component. It's not just musculoskeletal or even just like reproductive or GI. It's, you know, so knowing that, who to bring in and at the right time too, so that it's, they're not just kind of like chasing this wheel of like, okay, I've done this, and then I start back and try that again.
Right.
And not to mention, in 20 years, women can go from having their first period to having their fourth child, or from having no children to going through menopause. And it's like, well, like hormones govern everything. So sometimes we do need to step and kind of give respect to those hormones in the body system that are going on, then to do all those things in those different
time
and
frames. Sometimes also I found that I'll see someone who has seen, well, I've already been to physical therapy, you know, they've seen a pelvic floor physical therapy. Well, not all pelvic floor physical therapists are made the same. So then I'll say, well, did they do any sort of internal work? Did you ever use, you know, and then say it might be worthwhile to try someone different, because everybody has different techniques. And that is the other thing, is that sometimes it is worth going back to a thing if maybe it wasn't as successful, because maybe you need to find sort of a different person or a different fit that will work better. And so I really love the fact that you guys are so holistic in your approach. So when I talk to patients about you guys, especially if they've maybe been to physical therapy, but you know, I say they're going to look at your whole body, because that's really what you need. It's not just one system.
Right. Yeah.
Well, I don't know if you have any other, you know, kind of golden nuggets or anything else that you want to just kind of wrap up. You know, how can people contact you if they want to work with you, you know?
Yeah. So, I mean, I think that we covered a lot, so I'm really glad we were able to have this conversation today. Unfortunately, I don't have, you know, an Instagram. That's not how I would say for someone to contact me. So if someone were to want to contact me, my email address is my last name, Spivack, SP as in Peter, V as in Victor, ACK @rowan.edu. So they can contact me in that way, or call to make an appointment to see me. And we do have 2 different office locations. The phone number that someone can call for both of the locations, one which is in Sewell and the other in Stratford, would be 856-589-1414. And you can just let the front desk know you're trying to schedule a chronic pelvic pain appointment with Dr. Spivack, and then they will take care of getting the packet to you so that you can complete that prior to seeing me. So those would be the 2 best ways to get in touch with me and or schedule an appointment.
No, that's great. And then like, if people are from our office, like we will directly email you or call you and say, hey, you know, this client is coming over. And obviously if you're not in the South Jersey area, I'm sure between myself and Becca and Dr. Spivack, we can all find somebody who, you know, is a pelvic pain specialist.
Exactly. And there is a website, I don't have it off the top of my head, but where you can locate, you guys might be able to give it to the audience, but locate pelvic floor physical therapists in your area.
It's pelvicrehab.com.
Yes.
There's that group. You know, if there's specific things. Go ahead.
Yeah, so that is a way also. That's the one. So
excellent.
Yeah, does pelvic rehab have other providers on there as well, or is it just rehab?
I feel like they're starting to. I know that Global Pelvic Therapy, GFAM, by Tracy Sure, they have multiple providers like yourself, like different physicians and specialty groups that other people can look into as well.
There's another one, I'm just looking it up. It's so there's pelvicrehab.com and then ptl.womenshealthapta.org.
Well, that's a new one for us.
And then pelvicpain.org/public.
Yes.
So those are all places to locate a trained pelvic floor physical therapist. So there is the International Pelvic Pain Society, IPPS, is an organization that I work a lot that has fantastic resources, and you can locate on that, I think, pelvic pain providers. So you can go to the IPPS website and look to see about a pelvic pain provider near you.
Yeah, awesome resource. Thank you for
Absolutely. Well, I'm so glad that we were able to chat today, and thanks so much for having me on.
You're absolutely welcome. Well, we just appreciate, working with you and getting to know you and having you here in the South Jersey area. Look forward to many more, positive outcomes for everybody.
Absolutely. Totally agree. Keep doing the good work.
Exactly. Thank you.
Yeah.